Welcome, everybody, to this webinar from Matt and I, Fien Odontics, and myself. Thanks to Osteogenics for putting this on for everybody. We got questions about will this be viewable afterwards, and it will be. It'll be viewable through Osteogenics. So you please want to get in touch with them about that. Absolutely. This is a very exciting webinar where we're going to be showing some cases that are a little bit larger, a little bit more advanced. We're actually going to start with more simple cases and then move on to some larger cases. So we're going to be showing a real range of everything that we do in our practices. These are day-to-day things in our practices and things that we get asked a lot about, and we're happy to share it. We're going to include some little tips and tricks related to some materials that we love to use, and this is the real deal. So without further ado, I'm going to pass the baton off to Matt. Just as a housekeeping item over here, please keep your questions to the Q&A section at the bottom of the screen, and general chat. You can chat about anything you want in the chat, but keep the questions to the Q&A, please.
Thank you for that kind introduction, Israel. No, we're super excited to be here. We started putting together these cases actually a couple months ago, and we really want to share with you sort of the gamut of these smaller socket preservation cases, and then, like Israel said, start talking about larger GBR cases and start to get a feel for, what these procedures have in common, what themes resonate through each of these types of cases, whether it's a smaller defect or a larger defect versus, some of the things that we do differently for these larger GBR vertical cases that Israel's going to share with us in a little bit. For those of you that saw his posts yesterday on Instagram, that amazing Ptfe that's been buried for 20 months, he won't even let me see it. So he's going to reveal it tonight at the end. So you have to stick for that. And like Israel mentioned, also at the end, we'll do some, we'll present the CE code for CE that you guys will probably receive an email from Osteogenics. So without further ado, of course, we have a ton of material. We're going to kind of fly through it because there's some points that we want to make sure we drive home. And so without further ado, let's get started here. Of course, we all present with these situations every single day. We love those cases where we can do things flapless, do immediate implant placement, immediate provisionalization. But the reality is more times than not, this is how these cases get presented with large bony defects. We have to figure out ways to not only regenerate what's been lost, but to maintain those normal anatomic contours, which is so difficult to do. And really, what we always preach is not to fight it, not to fight for primary closure, because without getting primary closure, we're allowing the body to heal by secondary intention. We're not moving the mucogingival junction, which we all know, and we have this much greater band, much thicker band, which is protective. It's also recreating those normal anatomic contours. So having this keratinized tissue is key. And we oftentimes will try to fight it by getting primary closure. Take a step back, look at the cases that we present day in and day out. For most of the sockets, we're not getting closure. We will touch upon those cases where it is important. But just think about, I know you guys all have cases like this where you are doing a large bone graft at the time of an extraction and we fight for closure. And we're so proud because we have minimal tension and we get things closed and we know our bone grafts are going to heal well. But when these patients return 6 months later to uncover or to place our implants, we have this issue to deal with, these soft tissue defects to deal with. Why did I get closure here? Well, I had really a severe buccal dehiscence. I wasn't dealing with really favorable thick anatomy. And so I really pushed it and we were able to regenerate that bone. But as you can see here, I'm actually using a little palatal pedicle here to start to augment the soft tissue. So keep in mind, this is okay. And there are cases where you need to do this and get primary closure, but you should always think about doing things a little bit less invasive and relying more on what the body is giving us in terms of biologic principles, just like you see in this case. So this is really a run-of-the-mill posterior socket graft case that we all see day in and day out. Patient has a nice thick biotype. And these cases are, I find, to be some of the most dangerous because these patients have these lingering infections, but because their bone is so thick, their anatomy is so wide, that infection can't get out. And so it sort of sits there and brews until finally it breaks its way through the buccal plate. And that's when the patient comes to the office and says, oh, I think something's wrong with this tooth. So keep in mind, these cases can be treated with a lot of different materials, But often overlooked, not really talked about that much these days, are these Cytoplast Ptfe singles. And these are really, really convenient. They're very easy to use. They come with a smooth side and a rough side. And we usually suggest people use the smooth side facing the bone. And these can really be secured in such a simple fashion because, again, we're not going for primary closure. One of the benefits of using a membrane like this is that we don't need primary closure. So in terms of suturing, you just want to do something that's going to be very, very simple for you. It could be some sort of horizontal mattress or some sort of figure eight that you've seen, us do before. You could also just do single interrupted sutures. The key for me here is that we're deficient in the buccal occlusal line angle. And so we really want to make sure that when we're packing our bone, we're actually supporting that buccal occlusal line angle. And yes, Israel.
There may be a question about why use the rough side up and the smooth side down. And that's really related to the ability of the tissue to hold on to those rough bumps, those little dimples on the rough side of the membrane. And it helps the tissue stay in place.
Yeah, and that's a great point. And I think clinically there may not be much of an issue if you do accidentally use the wrong side. But again, remember, we're going to be removing this membrane. This is a non-resorbable membrane. And when we remove it at a couple of weeks out, we want to make sure that, it comes out easily. We don't have to worry about giving the patients anesthetic. So as you can see here, we're getting closure here with just a continuous type of suture here, nothing really too specific. You can see here, as I'm going from inside the socket to outside the socket, that's really a great way to go because you're avoiding the risk of pulling out that membrane as you're suturing. And so that's something to keep in mind. As you see here, I started to go from outside to in and I changed my mind, went back inside to outside. I think so that's a really nice tip. These cases, in general, I like to use this Ptfe Sutures as well. If you're thinking about it, these patients have to return to remove the membrane anyway. I like to have that membrane in about 3-4 weeks minimum. And so it's nice to have those sutures in place for that whole period of time, just keeping everything in place. And what you end up getting with these cases is really phenomenal. You get really excellent healing. This is how the Ptfe looks when we remove it. As you can see here, this patient did have a good amount of plaque and debris on the occlusal surface of that membrane. But underneath, we get this beautiful new zone of keratinized tissue that's currently maturing. As we take that membrane out, we start to see it. And
go ahead. Finish up that where you were going to say.
I was just going to say, if you were to remove the membrane a little too early, sometimes you'll see a lot of that particulate bone graft material. But this is really that sweet spot about 3 to 4 weeks when I'm removing it, and you kind of see that bleeding that occurs. And I really love to see that. And then at this point, I'll let the patient heal for about another 3 months or so, and then we're ready for our implant placement.
So what I was going to say is that with this membrane, because it's a non-resorbable membrane and it stays in for 6 weeks or so, it does allow for some plaque or otherwise food to go underneath it on the edges. And so it is important to make sure that the edges are tucked under the tissue interproximally so that plaque doesn't have an easy time of getting under it. Some of it will, and it's really not that big a deal, as you can see, but obviously it's better without that.
Yeah, and so obviously no dead space under that membrane. You want to try to keep it as taut as possible. And if you do that, and if you're patient and remove this membrane at about 3-4 weeks, like I mentioned, you end up getting this really incredible zone of keratinized tissue, but also we have really excellent bone underneath. Someone just asked a great question. Are you irrigating the area? No, me and Israel both really tell our patients really not to mess with the area. Obviously, we want them chewing on the other side, but I'm not looking for them to help me keep it clean too much. If it's somebody that's extremely anal, I have told patients to use like a Q-tip and just remove some of the plaque from the adjacent teeth. But I really prefer that they don't put any lip pressure, any tension on their lip. Really stay away from the area. I think that's your best bet. And if they need to rinse, maybe some warm salt water, but certainly not for the first couple of days. And you can see here when we uncover this, we have plenty of bone. That buccal defect that was a dehiscence that was very localized. That was where the infection was draining from, has been completely regenerated. No particulate bone graft materials here, no particulate remnants, and really healthy bleeding bone. You can see I've been working with Dr. Puterman for quite some time now. I started using some Straumann's in these posterior cases just so I could be like him. But you can see we have really nice healing. The bone looks very uniform. And these cases come in all the time. These patients do have thick biotypes, but just because they have a thick ridge structure and thick anatomy, there's always some complicating factor. In this case, the patient had a communication with the sinus in that palatal root. So I extracted the tooth and I noticed that there was a communication. And so I want a little extra security in these cases. Again, I can use the Ptfe really, really nicely here. And then this is something that I think is often overlooked, because someone just even in the chat just mentioned I can never tuck it that easy. Well, the key to tucking it is not rushing, right? We have these membranes that are pre-cut, so we kind of just want to get it in there. Well, you have to take your time. You have to do a nice sulcular incision, maybe 1 tooth to 1.5 teeth either side of the defect. You want to make sure that's to the bone, a nice clean incision, and then you want to do a full thickness flap reflection or a tunnel, and you need to make sure that that tunnel is prepared wider than the size of our membrane. If you don't do that, you're going to be struggling to get these membranes in. Now, this is not a collagen membrane, so it is a little bit stiffer and a little bit easier to work with, and you don't have to worry about it tearing so much, but you really need to make sure that tunnel is prepared wide enough to house that membrane.
And it kind of goes without saying, but do not use this membrane to seal that sinus perforation. What would you use there, Matt?
So I play around with a lot of different things. If it's as small as it is here, this is where I'll go and take like a collar plug or collar tape or something like that, and just sort of make sure that that opening is not patent, and then I can pack my bone graft there. In some cases, I've used a collagen membrane or an amnion chorion membrane down there, but for a case like this where it's so small, I really just love just blocking it with some collagen. What about you?
Yeah, I would do the exact same thing. I typically use sometimes a stiffer resorbable collagen membrane to seal that off, or some type of amnion chorion to seal it off. Yeah.
Yeah, and so the trick to doing it smoothly, as someone just asked, is taking your time with that flap elevation. Mm-hmm. And you can see in this case, this patient's very thick bones. It's not the easiest thing to elevate these flaps sometimes to get over that hump, that buccal ledge there. And that's where you just have to take your time, because once that tunnel or flap is excised and elevated full thickness, and you have one clean pouch to place your membrane, it really becomes a very, very simple procedure. I typically will do just like I'm showing you here, where I'll put that membrane in first. As you can see here, I love these for these posterior cases because they're usually perfect for these molar sites. For a premolar site or for an anterior, we end up having to start trimming this membrane because we don't want it in contact with the adjacent teeth. And like Israel mentioned, we want to make sure we can tuck it right under those papilla. And so this works really, really well for these posterior sites. We'll pack it and then we'll go get closure. Now, this is something that I do quite a bit. I don't really talk about it much, but for sockets, I really love to do this. I don't really love the idea of putting so many single interrupted sutures. Obviously, you can pull out your membrane. You're also putting a lot of tension on the flap margins. You can necrose the flap. And so I'll do like a horizontal mattress. Obviously, we're not getting primary closure, so we're not looking for dual layer closure here, but it's still taking those bites further away from the marginal gingiva, less chance of necrosing the flap. And so sometimes I'll do it just like this, where I'll do a horizontal mattress and I'll tie it off. Another little trick, since I really want everything to be kind of folded over and pushing down on my membrane, is I'll do what's called a Laurel modification. So I'll actually, rather than tying this off here, I'll take this tail and I'll run it through this palatal loop. And what you end up doing, as you can see here, is you end up having two sutures in one. You have like a single interrupted and a horizontal mattress combined, and it actually is helping to push everything down. And you can see those flap edges kind of get inverted a little bit. So it's pulling down on that membrane. And I really love to do that. And then as you can see here, I'm just putting a couple of other single interrupted about 3-4 millimeters apart, just to make sure that that membrane's bound down everywhere. And this is a really, predictable way to go. This is the sutures that we use for this. We always get specific questions about the size of the needle. Obviously, Israel and I don't do everything, exactly the same, but there's a lot of overlap. And this is one of those things.
One day I hope to.
Me too. Let me ask you this question. I know I've asked you this before, but I forgot the answer. For your traditional ridge augmentation cases where you're using Ptfe, are you using the 3.0 or the 4.0?
I'm using the 3.0 Cytoplast for the horizontal mattress. Yeah.
Yeah, I find that the 4.0 is so small, and then it's so biocompatible that when you do those horizontal mattresses, the soft tissue tends to grow over it. So I stick with the 3.0 as well. And here's that case healed up. And of course, we are going to remove that membrane again at about 4 weeks. And this is exactly what you saw in the last case. Almost looks like an identical case, but it's not. And I know that because this patient hasn't been back yet. But you can see again, that soft tissue looks really pretty. Some people comment that that tissue right over the occlusal, looks a little bit more immature than the tissue to the buccal and the palatal of it. And the answer is yes, it is more immature. It's newer tissue. It's not as thick. It does take a little bit of time. But I love in these cases being able to, literally the only cases that I'll do flapless, if I have a good CT, I can actually be very confident that I have good bone, buccal, buccal and lingual to where I need to be. So I think this is really something that we should think about doing. They're very inexpensive and they're very safe. This is how we remove the membranes at about 4 weeks. And you can see there's no anesthetic given here. The first time you do this, you think to yourself, ooh, how can I do this without giving anesthetic? But these patients don't feel it at all. They're very, very easy to remove. And remember, I just removed the sutures a minute before. Now, this case is exactly what I was talking about here, where I had to remove that membrane a little sooner because the patient was leaving town for about 6 months. And I ended up going back and doing the implant a couple of weeks ago. It looks great. I posted that on Instagram, actually. But you can see here, even removing it a tiny bit early, that blood clot's still stabilized enough that it will granulate in, which is really nice. Here's another case, very, very challenging. And this is really one of my main indications for this material is when I have very little kg to work with, very little KT, and I'll just take a shot, leave this exposed. And you can see here that band of keratinized tissue. There was really no other way to create that band of tissue without doing like a tissue graft. Of course, you still have that frenum that's holding me back here, but a very what I would call acceptable result here in a case where, when I first met the patient, I was very nervous about how much tissue they had and how I was going to eventually augment that tissue. All right, so looking at sockets, obviously me and Israel show plenty of cases where we use sockets, and of course we use collagen membranes. We also use these non-resorbable membranes. But when we start talking about larger cases, which is really what we want to focus on for the rest of this lecture, there's a couple things that we need to really consider doing differently or consider in general, because a lot of the time it's very easy to forget about some of these steps. Getting autogenous bone is going to be critical. We'll talk to you about that. We have to get very good at stabilizing. And I don't suggest that you get very good at stabilizing with just sutures or just tacks or screws. You really have to know all three techniques. And then, of course, probably the most important thing for these large ridge augmentation cases that can be a lot more, unforgiving is knowing how to get primary closure. And so we're going to talk to you guys about the tools that we use to do this.
So the biggest tool that we use over here, this is a safe scraper tool to be able to get some autogenous bone. And you always want to include some autogenous bone with your graft material. Autogenous bone is the only bone that's osteogenic, aside from using BMPs or osteoinductive, and we mix it with our allograft, sometimes using some xenograft as well, but mainly mix as much autogenous as you can. In this case over here, obviously I was augmenting the anterior centrals, but you can see how I elevated my flap all the way behind the premolars and then even went underneath created a tunnel underneath more towards the molars to be able to put the safe scraper underneath the flap and be able to get some autogenous tissue. You don't have to go to the ramus. You don't have to go to the symphysis. You don't have to go to the external oblique ridge. You can take it directly from your surgical site of where your recipient site of where you're grafting. You can use the anterior nasal spine. You can go more apical on the adjacent teeth. Really anywhere that you can get autogenous scrapings is where you want to go.
Right. And it just takes patience. It just takes a couple of extra minutes. It's not the quickest part of the procedure, but it's certainly worth it. Both of us use these safe scraper twists. They're really good access for the mandibular ramus area. But like Israel showed you, even in these anterior cases, just scrape, scrape, scrape. They're disposable, which is kind of nice. You use it once, you toss it, you get your money's worth. Okay. And the difference is that if you're using autogenous, you're going to get bone that looks like bone. The biggest question we get is, how come I did this big bone graft and, it didn't turn over? And then we start asking questions like, well, did you use autogenous? And you get that look. So keep in mind, if you want to get really stable, predictable results, you need to start working autogenous into the mix. Bone grafts will all look the same. It's a mineralized, deep proteinated material, but without that life to it, you're just asking for failure. Okay. And then of course, the most important thing for all these ridge augmentation cases really is knowing how to get soft tissue management. I always get a kick out of seeing some of Israel's cases where he just has added so much bone volume, right? Because we know that it's going to shrink back 20, 30%. And I always think to myself during those surgeries, okay, how am I going to get this closed, right? Well, we know how to get it closed.
Yeah, this is a case where I'm working near the mental foramen, and you can see the angle of the 15 blade travel up towards the crest. You want to keep a good 10 millimeters away from that foramen, but even around that foramen, you have to be able to make an incision into the periosteum to be able to get good stretch. This is a technique that I learned from Fien Puterman, who's obviously a world-renowned expert when it comes to this type of thing. Recommend always for you to take his courses and for some more in-depth material here. But you can see how this is just barely an incision into the periosteum, and then take my measurement of 10 millimeters away from the mental foramen. And as long as you stay away from that, you have to get comfortable to be able to get that release, because that area is a tough area to get release. You don't want to get too close to the mental foramen. You don't want to end up with paresthesia, but you have to learn how to still augment that site.
And a couple things that we always talk about, we always have 2 blade handles on our surgical trays, because you're using a blade to make your initial incisions. You do not use the same blade. You need a brand new sharp blade. And these 15Cs do get dull relatively quickly. And the reason why that's so important is, as you noticed, when he was releasing that, he was only going about 1 millimeter deep. And the reason for that, we'll show you on the next slide. But the idea here is not to create unnecessary trauma, not to cut all those deep blood vessels. So the first step in soft tissue management is that 1 millimeter deep periosteal releasing incision. And Israel will show you another great video here. And then the trick we'll show you as well.
Yeah, so this is a similar case where, again, you can see that 1 millimeter deep incision, and then using the mini-me elevator to be able to separate the tissue, to separate the tissue on both sides of that little small incision. And that's where you want to get that stretch. And you can really get that stretch way over. We like to test it by seeing if the tissue will rest over the occlusal surfaces of the adjacent teeth. And you can see in this area, even on the lingual aspect, I'm pushing with the dull side of the mini-me just to be able to get some stretch on the lingual. There are no vertical incisions there, but you can see how the tissue is actually going to rest on the occlusal surface of that molar. And if the tissue rests on the occlusal surface of the molar, you're going to get good primary closure.
So in the first step, you're doing a 15C blade, making that 1 millimeter deep incision. Then you're using the mini-me, which will show you what this looks like here. It has this very favorable angle to separate those subperiosteal fiber bundles, which is what's keeping you tight, which is keeping the tension. And then on the lingual, you were using the opposite end of the mini-me instrument to separate the buccal flap from the superficial fibers of the myohyoid. So that's a really important step. And of course, you noticed where he made his buccal incision, right? He had to move far away from that mental foramen to protect it. That's why he needs this release on the lingual in a lot of cases to be able to get that dual layer closure.
And of course, without that, much more challenging is the maxilla, where you really have to make sure you get good release and test it by covering the occlusal or incisal surfaces of the teeth, just like Matt's doing over here. You don't have that palatal release that you can get like you do on the lingual aspect.
I'm actually honored that you think this is my picture. But
it's is it mine? No.
I've never taken a picture this pretty before. Come on. But no, this is key. And before you start getting closure, make sure you have enough release. You check it multiple times. I think that's very, very key. Okay, so this is something that's really fun for us to talk about, these different stabilization techniques. When me and Israel first met, he was tacking and screwing everything, and I was suturing everything. And now we've sort of blended. He showed me, ways to do this that we're going to share with you tonight. And of course, we're both learning different things about suturing and teaching each other as we go. So the most important thing here is, keep in mind, we've already created our periosteal release. That's why we talked about soft tissue management first. When you're doing these procedures, you want to do that releasing incision, that stretching earlier on in the procedure. For many reasons, but one reason is it allows you to, get rid of a lot of that heavy bleeding that you have right after you make that incision. You have some time for everything to kind of stabilize. But the other reason is, of course, if we're going to use sutures to stabilize, we need something to grab onto. And now we can grab onto that periosteum, that apical periosteum. And there's, of course, millions of different ways of doing this. This is probably the simplest way. We've used our 15 blade. We've used our mini-me to separate those subperiosteal fiber bundles. And then we'll start suturing. And the first thing I'll do is just bite the periosteum. We'll have that go through the periosteum, go over our membrane, and then we're going to anchor it to the palatal flap. Now, this is very important. You need to make sure that you're anchoring to that palatal flap relatively apical, because we still are going to want to get dual layer primary closure here. And in order to do that, you need to have that connective tissue interface of 5 millimeters or so. So you really need this horizontal mattress to be probably more like 7 millimeters deep on that palatal side.
Now, what's your suture of choice when it comes to these?
I don't want to give it away because we're gonna cover that, but I think that was a great question, and I think the color of my animation here, I think, is a little bit foreshadowing, because as you can see here, I was doing a lot of these with chromic gut, and while the smaller defects, it would really hold very, very nicely. Of course, there's a lot of apprehension when you're talking about stabilizing your GBR membrane with a suture that only lasts a week. And this is a perfect example. I'll show you this case here. You can see that we had quite a big moderate concavity. And this is that case where you open it up, you can get your implant in, and then you have this decision to make, well, do I augment? Do I just let it ride? Well, if I have a simple way of fixing this, I'd much rather do it at the time of the implant while the site is free of any bacteria and things are really ripe for healing. You can see the bleeding. And so we got closure here. And then at about 5 months post-op, using that native collagen membrane and just some simple chromic gut sutures, we have our implant completely buried in bone, normal anatomic contours. And that's where I want to be sending this case back to the restorative dentist, in that state.
That's a beautiful case.
Israel gave it away here. So Israel's going to talk to you a little bit about how he started using this stuff. And you see one of his beautiful cases here.
So I've been using Glycolon for, I don't know, maybe 6 years, something like that. And Glycolon is a really, it's a beautiful suture to handle. It handles much like polypropylene, and it is resorbable. So it's kind of best of both worlds. It is a monofilament. It ties very securely. It doesn't come out. Sutures, frankly, I haven't seen mine come out ever. And I used to use the 5.0, and now I pretty much exclusively use a 6.0, only because I'm seeing fewer patients for suture removal during COVID. Some patients are saying, you know what, if these sutures are resorbable, why do I have to come back just for an implant or something like that? Why do I have to come back to take out stitches in 2 weeks? And they're right. They don't necessarily have to. But using 6.0 is much easier because they resorb a little quicker. They do resorb at 4 to 6 weeks. And in this case, you'll be able to see what happens to the sutures at just 2 weeks. And you can see that case where obviously number 8 had to go, internal resorption. This is how I left it with a collagen membrane exposed. Actually, that was an amnion chorion membrane exposed. And just 4 simple interrupted Glycolon sutures to close up over the membrane. And you can see the occlusal view. And then at 2 weeks, take a look at what the suture looks like. You can see the suture starting to lose its dye. It's becoming more clear. But if you take a really close look at how the tissue handles, how it heals in relation to the suture, it really is just unbelievable. There is no inflammation there. There's not an ounce of redness around these sutures. It just completely heals together with the suture.
And I think a good point is you mentioned a little bit, it comes dyed and it comes in an undyed version. I'm exclusively using the dyed version. I've accidentally ordered the undyed version, and it handles the same, of course, but unless
your loops on.
Yeah, unless you're using really strong loops, go with the dyed. It really makes it nice. And it gives you some confidence too, as you see it start to resorb and change colors and lose that dye over those first couple of weeks.
Yeah. And you can see all the knots are still intact at 2 weeks, but you could see how the tissue is just very, very happy being up against it.
I love that concavity, that, anatomy that you were able to preserve here.
Yeah. Thank you.
No problem.
I like the healing with the membrane too. And here's another case. This is a free gingival graft case. And you can tell for the periodontists in the crowd, you could tell I got a little fancy. In the middle 2 teeth, I did my suturing, my stabilization sutures or strapping sutures, crisscross. And on the outside, I made them parallel. And I wanted to see, I do this sometimes on cases just to see if it makes a difference. And frankly, it doesn't. I've done it on a bunch of these cases. But you could see this is at 2 weeks. 2 weeks healing. Patient hasn't been brushing. I've told him not to brush. You could see how beautiful the healing is after 2 weeks. But take a look at the plaque on the lower right side. And does the plaque even bother the sutures? It doesn't wick plaque at all because it's a monofilament. But look how healthy that tissue is, even with that food and plaque built up onto the suture. I don't know of another suture quite so nice like that. Here's a case doing a vertical GBR with tenting screws and collagen membrane, and using the glycolon sutures. And this, I love this case only because Matt loves this case.
I do love this case.
And Matt, we aim to please each other. And Matt loves this case because of that suture that I put in between the two premolars, or is it premolar and canine? I'm not quite sure now. But he likes that suture because it's an extra suture laterally that holds down the membrane so that the membrane doesn't flop and bone graft doesn't escape.
We just got a great question. Someone just asked, how are we tying the suture knots for glycolon? And that's a very good point. Osteogenics actually has given us a copy of some literature where they did some studies on knot removal strength. And what they're actually saying for PTFE and for glycolon, the strongest suture that you can do would be that 2 forward, then 1 forward, then 1 back. And I know Jenna.
Do you do that?
I do it sometimes. I don't see a difference. Before I've seen that study, I was already using glycolon for probably 2-3 years because of you, and I was just doing it the traditional square knot. So I don't see much of a difference. I would do what's comfortable for you. If you're finding that your sutures are getting loose too early, that's another story.
Yeah. Jenna, I hope you're healing well and icing as we speak.
I saw her case yesterday and I got a little nervous when they used chromic gut, but we'll see how that heals.
Chromic, I didn't notice that.
It looked like chromic gut, Jenna. Jenna, tell us, was it chromic gut? It looked like chromic gut to me. In any case, you can see Israel did a great job here holding down the membrane. There's a lot of different ways to do this. We'll talk about, really the simplest way, in my opinion, is to do something like this. And Ryan knows, put this together for us really, really quick, which is amazing. I love this diagram. And he modified it to show a couple things that I wanted him to show. First of all, notice how the membrane extends laterally past the defect, just like Israel showed. I think that's really, really smart. And then in that first illustration, I showed you how I was going through the periosteum twice. So it was basically just a horizontal mattress. Well, in this case, it's 2 separate mattresses. And I think that's the easiest way to go. In a lot of cases, this works really, really well. As you can see here, I had 2 implants within the housing of the bone, which makes me feel really good. But of course, we had those buccal defects. I'm using a collagen membrane and I'm stabilizing it just like we're showing in this diagram with these 2 horizontal mattress periosteal biting sutures. Notice my knots are on the lingual. I started putting the knots on the lingual in a lot of cases because I felt like I was able to get better even tension. And in a lot of these cases, patients are wearing partials. So it was kind of covering over the partial with covering over those knots, those loose ends with the partial. And patients weren't really complaining about it. But while that suture sticks around for 6 weeks, it does get softer and softer. And so I'll leave my tails on the longer end rather than short, just so it doesn't poke them. But patients really don't complain about this. And I'm finding that I do get more consistent results using this suture that lasts longer than that 1 week chromic gut that I had been using.
And for some reason, I got on the train of putting those knots on the internal aspect, maybe because DC patients complain more. But
yeah, and I think it's certainly
no difference. Whatever feels good to you.
And because this material is very antibacterial, I don't worry about those knots under the flap. That's not why I'm not putting them under. I find that I can get more even tension, but I think that's certainly preference. Here's another case. This case was a little bit more complex because of where the mental foramen was. So I trimmed my collagen membrane around that mental foramen. Another thing I love about this picture is it shows that we can actually tuck that membrane just ever so slightly under the periosteum and help it keep it secure while we pack our bone graft materials. Now, this membrane is nice because it loses all of its memory really nicely once it gets hydrated. And because it was sitting there so nice and clean, I decided, let's just keep going with it. And I did more of a lasso that like Dr. Nieva describes. And the benefit of this is that now you have even tension over all of your sutures. So this is not a bad way to go either. Again, you see my knots on the lingual and you can see just how much I'm able to overbuild outside the housing of the bone. We like to overbuild. expect it to shrink 20–30%. So we always are overbuilding. And here is the next important step, which we'll talk about in some of Israel's later cases, but again, that dual layer closure. In this case, notice, even though I was using those glycolon sutures for the internal stabilizing sutures, I'm still using the Ptfe, or I was still using the Ptfe in a lot of these cases for those horizontal mattress sutures to get dual layer closure. And then it's simple enough. Once you are at that step, it's very easy to put some single interrupted just to make sure that those flaps are everted. All right, great bone at about 5 months. And, certainly can put those implants in that ideal prosthetic position without any compromise here. Okay. Like I just mentioned, I'm not really even using those Ptfe sutures quite as much as I am using the glycolon now, that we know that they stick around, they keep their tensile strength for at least that 2 to 3 week period, which I think is really all we need. And the most difficult part of these surgeries, in my mind, these post-ops, were removing those Teflon Ptfe sutures. So this was another case where I definitely was considering doing this flapless, right? I got these teeth out flapless. They were perio compromised, but a very young girl. And I really wanted to minimize surgery, but at the same time, you can get a feel for the shrinkage that she had on that other tooth that was already previously extracted. And I had this decision to make. Do I place these implants flapless or do I open it? Well, I decided to open it after bone sounding. I had defects that certainly could benefit from some ridge augmentation. I was able to stabilize an Ossix Plus membrane. In this case, this is a 25×30 with a combination of some horizontal mattress. You can see I'm crossing over the membrane here and I'm biting the periosteum pretty far laterally just to make sure I'm holding that membrane down. Now, this is a very tricky area to use these sutures, in the anterior or any area where you're really going around the curve. These longer spans are always a little bit more difficult. You can see here, I have one of the sutures on the lingual and I have one on the internal. So it's not as if you have to decide one or the other, but again, this is just like Israel's soft tissue cases, where look how this soft tissue is healing at about 2 to 3 weeks. It's pretty incredible. And even in that center area where it's slightly open and I see some new soft tissue growing in there, there's absolutely no sign of inflammation, which is really, really comforting. And at that 2 to 3 week period, patients sometimes don't even know that the sutures are even there anymore because they're so biocompatible. You can see the beautiful healing at about 4 months. Probably closer to 5 months by the time I got the implants in. And you can see here, we definitely were able to augment that ridge. This is a case where you really need to overbuild these anterior cases. They have a lot of lip tension and also getting around that curve. So we had a satisfactory result, but notice how much it does want to shrink back if you're not using tenting screws or you're not using a titanium reinforced membrane.
You went fancy in the middle over here, I see, with the Laurel.
Yeah, that was like another, I just throw that in there every once in a while. There's probably no need for it here at all. But just trying to get as much closure as I can here with, without tension. And you can see it doesn't have to be so clean at this stage of the game here. I'm putting healing abutments in to support the soft tissue. Again, what would you expect with those glycolon sutures? So I'm using these even for cases where previously I just would have used chromic gut. They're just very nice that they're holding for as long as they are.
Yeah, I like to keep things simple in my office. And if I ask for a suture, they don't ask me which one. It's just 6-0 glycolon. Keep things simple. It's easy.
And here's the case that just got finished. And I think we did pretty good from where we started in a patient who had obviously a genetic, predisposition to disease in this area. So I'm pretty confident now if we can get her in regularly and keep this clean, we'll be in good shape. And then here's another membrane that I've been using a lot more now because of its handling properties. This is Z Matrix, and this is really nice. This is a porcine peritoneum, and one of the things I like about it is that, of course, you can use sutures, but you can also tack it. Most of the cases I'll show you, I'm using sutures, but again, this is very similar to the previous case where I have a buccal dehiscence on that first premolar site. I have the mental foramen right in the way. A little bit difficult to maneuver around that. I use the Z Matrix dry. I insert it dry. I'll pack my bone and then I'll hydrate it right at the site, and it really does lay down very, very nicely.
I love how you decided not to disturb not to disturb the implant tissue behind it.
This is an interesting case because this is one of those patients. This is the nicest man in the world, and he comes in regularly for everything. He comes in, he'll do whatever you tell him, but he was walking around with 2 abscesses on these 2 anterior teeth. And the plan was to do the whole quadrant at once, and it just didn't play out that way. But yes, that was my implant that I had placed a couple months prior. So I definitely wanted to try to keep that tissue there. And for me, one of the biggest tools I have in that posterior mandible is that distal buccal releasing incision. So even though I wasn't touching the implant, I still wanted that releasing incision to help me get closure. And you can see again too how this membrane is sort of adhering to the native bone and it's moving laterally. So that really is just going to help me secure my bone graft. Here's the healing. We did very well. I was complaining to Israel. My flash settings are all messed up on my camera thanks to David Attia. I'm not going to go into it.
David.
But
what does he know about photography, that guy?
I don't know. I'm trying to do what he's doing and I screwed up my settings. So now I'm hopeless, but this is how that case healed. Very beautiful bone, great torque. Actually, you can see that middle implant I torqued out. I needed to go and put that down a little bit further. And again, this is just illustrating that with this suturing technique and by using your imagination, we can really get things very, very secure and really build things out. So this is Z Matrix as well. This case I just completed. And then as luck would have it, today I did another Z Matrix case where I just was able to place the implant. So here's how the patient started about 4.5 months ago. Extracted that posterior tooth, had a buccal dehiscence. If it was just that tooth itself, I think we could do really well with many different membranes or many different more minimally invasive techniques. But in that anterior site, that tooth had been missing for a while, and we certainly had a moderate ridge deficiency. Always, if I'm doing ridge augmentation, I'm creating those intramural penetrations that you see here, that nice, beautiful bleeding. And then I will secure, just like I've showed you a couple of times already, with 2 simple horizontal mattress biting stabilization sutures. And those knots are on the lingual. And that Z Matrix, it adapts very, very nicely. You can see here how it's bulked out. And so just like Urban, when he's doing his sausage and he's getting it really, really plump, that's what we're trying to mimic when we're using stabilization sutures. And again, I told you I'm getting away from using the Ptfe. This is just the glycolon. I have a little bit of overlap here. Didn't do a great job of getting that dual layer closure, but nonetheless stayed closed. Have a little bit of a cleft there that we can definitely deal with at the uncovery. And then this is me at about 10 o'clock this morning, uncovering this and thinking, well, this worked well, right? So really a very simple way to regenerate these lost ridge contours. I see Israel, he's going to get some of this membrane tomorrow, I think, after seeing this. But it's the handling of the membrane that really makes it advantageous for this type of technique. And then I think using stabilizing sutures with glycolon, it's just very, very, very simple. But don't think you can treat every defect just with sutures. That's probably, the biggest question that we always get. Well, why are you even using tacks and screws? There's a reason why we use tacks and screws, because sometimes you just need more stabilization. And this is a case where I used a master pin system, which is the system that Dr. Urban actually developed for his sausage technique. And there's really a lot of advantages of this particular kit because of the fact that those pins are so strong, right? And you can actually go at it at an off angle. And Israel will talk to you a little bit more about using pins and tacks in a second. But the key here is, again, making that membrane taut. Probably the best advice that we have for you in this is to use the tacks in the most difficult accessible place first. So in this case, we tacked on the palatal first, or the lingual. We packed our bone, and then we secured that membrane on the buccal side because that was the side that I had a lot more access to. Okay, here's our closure. And again, you noticed how much we overbuilt. And so it's a little bit of a game of overbuilding and predicting how much it's going to shrink back. You can see that master pin here. You can leave these pins in. In this case, obviously, it's right there. I'm going to remove it. It's in the way of my implant. While I love using the pins, Israel, not so much.
So the reason why I kind of got away from pins is that, number one, I don't like tapping on people's heads. And number two, I like tapping on my own head. But number two, access is really challenging when it comes to certain times. When you're doing the palatal, you notice his palatal tack on that last case was really up towards the crest because it's as low, as apical as he can go. And sometimes you want to go more apical, and tacking in that way is just not possible. So we started to use screws, the Profix kit, and I was using the Profix kit for other screws for other purposes. And they also have these 3mm screws, which Urban actually taught to use with the titanium reinforced Cytoplast membrane, but not for collagen membranes, not for a sausage technique. So why not for sausage? It's because it's a little bit challenging to use. I was just texting with John Kim at Rocky Mountain Perio a couple hours ago about this exact topic. And, this is really challenging to use. So, but there are tips and tricks, and we're going to go through certain things like this. Number one, if Matt is securing this on the lingual aspect, like you said, first on the toughest part, if his assistant is not holding on to that membrane with the pickup, this is what happens. It spins around. And if you notice, he's not going very fast. He's on the implant setting on his motor, and he's on 5 Newton centimeters. And that's all that you need. Just put it onto 5 Newton centimeters. Sorry about the earthquake behind me. It's bedtime for my kids. I don't know. Can you guys hear that? But anyways, this is an example of how it is when you're placing a suture. Note the pickup, and that's most likely my assistant in this case. And also note the edge of the membrane. You see how there's excess, and I'm trying not to put the screw right at the edge. If you put your screw right at the edge, you can get a tear. You notice my assistant holding it there so it does not wrap up in the threads of the screw. And then once you release, tilt it sideways, and there you go. And you notice that excess amount of the membrane. You want that. So use a membrane that's a little bit larger than what you think that you're going to need. Don't over trim it. The biggest mistakes that we tell people during our courses are don't under add graft, or don't add too little graft, and don't over trim membranes.
Absolutely.
So if we look at a case where that's being used, here's one of my favorite patients, and unfortunately going to be losing tooth number 8 in this scenario. So I go ahead and place an implant. Everything looks great over here. And then you get that text, "Doc, my implant fell out." And we laugh and we say, ha, ha, ha. No, it's not the implant. It's what's called a healing abutment. And then you get that text back that says, "I'm not so sure." And you say, So yes, implant fell out. This is Matt's case, and that doesn't happen to me. Actually, no, this is my case. And this wouldn't happen to Matt. So I take a look at this, and why did this happen? Frankly, I don't know. This is not something that exactly happens often, but you look at this, and it wasn't outside the alveolar housing. You could see that osteotomy is still within the housing of the alveolus. Frankly, don't know what happened here. So go ahead and do a GBR, and you can see how in this case, I actually did not place my screws on the most challenging part first. Looks like I placed them on the buckle aspect first, but that definitely is rare. And you could see adding in more bone than necessary, overbuild the ridge. And again, look at the tack on the patient's upper right, and you can see, or the screw, and you can see that there's excess around that screw. It's not on the edge, so that you could prevent some tearing of the membrane. This is the sausage technique with a native collagen membrane. And you look at it from the occlusal aspect. We always get questions about how close to the tooth can you get. There are some realities and some fallacies about that. Reality is with a non-resorbable, you need to leave 2 to 3 millimeters away from the tooth to allow for soft tissue attachment. But with resorbable collagen membranes, you do not. So you can see in this case, the membrane is really almost wrapped up around the teeth. I'm using a Cytoplast membrane in this case for the horizontal mattress, and glycolon sutures for the rest of the area. And here's looking at the occlusal view, nice passive closure.
And this is a perfect example of those cases where, okay, you've had a failure. Now you're not going to do this without getting primary closure, because now you're throwing everything you got at this. You're going to.
I'm not treating that like a socket. Exactly.
Right. You're treating this like traditional GBR. At least you had the tissue to work with. You got beautiful closure.
Yeah. And so you look at the CBCT after about 6 months of healing, and you can appreciate the screws, and you can appreciate where the bone is, and open up the site. And this bone is dense, rock hard bone. And place my implant into, again, an ideal position. And you can see that excess bone that's built up. That bone is not going away. And for a patient who literally had her implant fall out of her mouth, looking at this, I think this is a very fair restoration. This is a very fair result, and she's thrilled with it, of course, thankfully. Here's another case. So this is a vertical defect and buckle defect. This is a three-dimensional defect. So how do you build a three-dimensional defect that's in a socket? So it doesn't show the x-ray over here, but the inferior alveolar nerve was immediately underneath this socket. Deficient buccal wall, deficient lingual wall. So if I'm going to be using a tenting screw, then I cannot place a vertical tenting screw. So to circumvent that, at the moment, I decided to place two tenting screws, but laterally into lateral bone. And just to be able to support the overall volume of ridge. And you can see 9 months later, this is a vertical GBR. So I'm waiting 9 months. And you can see what the bone looks like on the CT scan, and you open it up, and again, rock hard bone. And you can see the mesial tenting screw. Can't even see the distal tenting screw head.
Was this the first time that you ever put screws in the socket? Because when I saw this the first time, I was like blown away. It never occurred to me to do this. And obviously it worked out great. This was your first time doing it?
Yeah, first time. I was literally, because I tend to, and we're going to get there, but I use Cytoplast, titanium reinforced Cytoplast membranes a lot, but I tend to follow a rule of don't use it at the time of extraction, because in order to have a very nice result with titanium reinforced membranes, you don't want to have exposure. Can it be left exposed? Yes, but it's much, much better for your GBR cases to not have it be exposed. So I tend not to use it at the time of extraction. So I was going through this in my mind. Well, what do I do if I'm not using a titanium reinforced membrane? I can't place a tenting screw straight up vertically. What else can I do? And it somehow occurred to me, thankfully. And yeah, thankfully it worked out well.
Yeah, and this case resonates with me as well, because when I've been using the Profix kit for quite some time, but I was always using the handle driver, of course. And obviously in this case, you're never getting that screw in with the handle driver. You need to use the implant motor driver, that little piece that you saw Israel using, and that allows you to get access in areas like this. So a lot of us are afraid of hardware. It's very difficult to, use hardware while you're working with a membrane, but for tenting screws, it's actually quite simple. You don't have the membrane in the way, you have very good access. And then if you use that handpiece driver, it really simplifies things for you.
Yeah. So here's another case with mandibular centrals that are obviously floating in the wind over here, and leaving this patient with a nice sized defect after extracting the teeth. And you can appreciate has both buccal and lingual deficiency like the last case, but at least they're really good interproximal edges. So with the interproximal bone being so high, I'm thinking that I can probably regenerate that as long as I can gain some type of enclosure of the bone, some type of support for the bone to avoid soft tissue collapse into that site. So again, what are the ways to be able to create that? Either titanium reinforced membrane, but it's at the time of extraction. So I go to resorbable membrane with a tenting screw. And this is a single, this actually is not a tenting screw. This is a fixation screw. I tend to like the fixation screws better than the tenting screws. That's just my personal preference. I think they give a lot more flexibility. So, and you know that by the threads going all the way up to the top. So I put my screw with the screw head really right up to the top of where I don't want any collapse more apical to this. And you add your bone tissue. And you can see that three-dimensional, add bone way over the screw head. And again, like Matt said, you want to be able to overbuild these things to the point where your assistant's kicking you under the table and saying, hey, doc, how the heck are you going to close this? So build it up. I use resorbable collagen membrane over the top of it. Use the Periosteal suture in this case, and close it all up. Somebody may note that at the beginning, I did not have verticals, and now I have verticals. Do whatever you need to gain closure. If I obviously wanted to try without vertical incisions at the beginning, noticed I wasn't getting enough closure, so I made verticals.
And the other option would be, you extend all the way sulcular past those canines or premolars. Now, when you're going to get primary closure over the edentulous site, now you're bringing that tissue up so high on the other teeth, which isn't great either. So I actually like that you modified that, went with the verticals here. And we always talk about this. If you're going to do stabilizing sutures, you need access to the periosteum. And sometimes at least one vertical is really going to help. Just obviously know your anatomy, know where you cannot place verticals, but they certainly come in handy.
We are going to answer all these questions afterwards, no question, but just one quick question about that last distal tenting screw. I did not remove it. I left it in place. So here's looking at the CBCT. You could see the bone graft that's covering the tenting screw, and you could see the nice buccolingual thickness, which is really helpful. And after how many months? 9 months, because it's vertical. You go back and you look and you see, wow, there is bone all the way to the top of the tenting screw. And if you look at the bone in relation to the adjacent teeth, the facial of the adjacent teeth, it was right there. And you can see the three-dimensional volume over here. Basically take out my tenting screw, put the implant pretty much in that same spot, and have one of my favorite guys, Dr. George, make a nice cantilevered restoration, nice screw routine restoration. In this day and age, you could see that buccal deficiency that's still remaining, more of a soft tissue deficiency. In this day and age, I might put something in there. I might put some type of material to be able to bulk that up a little bit and make it more natural looking. This was probably done about 3-4 years ago.
And, so what you can see is that we do quite a bit with these collagen membranes, and I probably don't use the tenting screws as much as Israel does. But again, it's all about understanding, what you're trying to accomplish. You need to maintain that buccal-occlusal line angle, and it's very easy to maintain that if you're using a titanium reinforced membrane. But if you're not using a titanium reinforced membrane and you're using one of these two techniques that we were talking about, you need to get really good at stabilization. And if anybody's interested in taking our hands-on course, you can use this QR code here, get on the wait list, and hopefully we'll be announcing some course dates soon. Well, one thing that I am always amazed of is seeing Israel's Ptfe cases. And so I'm really looking forward to this, but first he's making me present a case. So I'll show you one of my cases first. For Ptfe, I think it's very important to get good at using collagen membranes because it's all of those same principles, right? We need to get autogenous in the mix. We need to get great at soft tissue release and tension-free closure. And then we need to get really good at stabilizing these membranes. Now, they're a lot more resilient because they're not going to tear on you quite as easily, but it's not the easiest thing in the world to do. It takes some practice, and we'll show you some tips on how we've gotten better at it over the years. This is a case that presented, and from that occlusal view, that soft tissue view, you see this great healthy tissue. You would really kind of be tricked into thinking that this was going to be a straightforward implant case when you see from the CT that we have a combination buccal and palatal defect here. And you can see, of course, that where the implants need to go is going to basically destroy or obliterate that bone that we have left. And so in a case like this, I'll go ahead and use the Ptfe, create my vertical releasing incision because I need to get access all the way to the depth of the defect. You see I've created intramural penetrations into that buccal plate to get bleeding. And then I'm using the same sort of screw that Israel had just showed you in that last case. So for me, in a case like this, I'm maintaining the buccal occlusal line angle here. That's really the goal of these tenting screws. And
all of these screws are all in the same kit. The 3mm screws, the 14mm screws that I used before, it's all from the ProFix kit.
Yeah, and you don't know before. This is one of those things, whenever I'm doing a case coming up, I make sure that I have a stock of different sizes, right? Unless you're really going to do an over-the-top job of reviewing that CT scan and making your measurements. A lot of the time, the final decision is made at the surgery in terms of the positioning of those and what angle they're coming out at. So I like to have an array of the different sizes available. And you can see here just how much of that screw we're leaving exposed. So that's about 7 or 8 threads, 7 or 8 millimeters exposed. This to me is the trickiest part of using these Ptfe membranes. First of all, they come in so many different sizes, and then you have to cut it and have it like we just said before, the biggest mistake with collagen membranes is over trimming it. Well, we can do that with our Ptfe membranes also. If we over trim it and then we're adding this huge volume of bone under our bone graft, it really loses our ability to estimate how large our membrane has to be. And so using a template here is a great idea. I just got a 3D printer just for the purpose of printing out some of these CT scans, some of these STL files, so that I can preform if I want to do titanium mesh or do Ptfe. I think it's really a smart idea.
Did you really?
Yeah. I mean, so far,
I didn't know this.
I mean, I've told you. So far, I've only printed 2 owls, but I'm getting there. I've got the STL files. I'm ready to go. Next case, I'm living it up. But because to me, this is where I would spend the most amount of time during surgery, is figuring out how to trim it. And, these corners are not great. But as long as it adapts very nicely, you can get these really in place. And once I have this closed, it's super comfortable. It's not like when you're doing stabilization sutures, and then as you're closing, you're worried about things moving. Once you get it to the point where this is fixated as nicely as it is here, it's not moving. And then, of course, the next step here is going to be to make sure that you get really good soft tissue tension release. And we do that with our periosteal releasing incision. And then I love this photo because it shows you that without single interrupted sutures, without even those final sutures, because we had adequate periosteal release, those horizontal mattress sutures are basically holding everything together. And
you could probably leave this as is and it would heal fine.
Yeah, it would probably heal with secondary intention, just because there's literally no tension and there's so much connective tissue to connective tissue interface. And that's one other point that I kind of glossed over in the first slide of this case. The benefit of a patient like this coming in with all this thick tissue, this is a great indication for this type of material, because you don't have to worry as much about things, dehiscing later on. And again, the purposes of that horizontal mattress suture gives you that dual layer closure and that soft tissue interface. One of the biggest things that everybody asks, and I already saw a couple of questions: how did you tempt that case? How do you tempt that case? In most cases, we're using a removable partial or an Essex retainer. That's really our options, except if you have a really good dentist, or in my case with Israel, if we have a really good prosthodontist or a really good dentist that thought about these things beforehand and treatment plan the adjacent teeth for new crowns, that puts us in the best position possible, because I can actually take that fixed partial denture, that acrylic temporary, and I can reduce from the cervix so that I'm putting absolutely no pressure on my graft, and that's absolutely critical. This is the healing at about 7-8 months. You can see we're going to raise a flap to get our implants in, and that membrane does come up pretty easily in most cases. Maybe sometimes we'll talk about that, but in this case, you can see we got complete fill of our defect, and we've grown that 7 to 8 millimeters of bone just like we expected to grow, because we were using that tenting screw.
That's amazing case.
And again, this just goes back to, the most difficult part of this procedure is probably adapting the membrane here. So I force Israel to take these videos so he can show me how to do it when it's more challenging.
That's right. So being forced to take the video, I did take the video, and you can see over here, these are just 3 millimeter screws, these little mini screws from the ProFix kit. And like we talked about, place the most challenging areas first so that you're not working over the bone graft in a challenging spot. Place one palatal suture and then place the other palatal suture. There's just no way that you can do this with a mallet and tacks. And this is, again, just 5 Newton centimeters. Once you come to that 5 Newton centimeter, you hear the beep and you turn to the side and it all dislodges. So now place the bone graft to fill this defect. In this case, was just done probably about a month or 4 to 6 weeks ago or something like that. And because I do this a lot, I do this really quickly. See how quickly I add that bone? It's very fast. Very, very fast. And then toughest part can sometimes be on the facial over here. I'm placing this 3 millimeter screw, obviously avoiding nearby anatomy, but I place this 3 millimeter screw, but there are definitely times when you're placing it and you don't quite get a good grip and it slips off. And that happens probably, honestly, 30% of these screws. They don't all go in quite so easily. And it's okay. Don't get frustrated. It's really easy to get frustrated. And my assistants will be the first to tell you that I do get frustrated, but just keep at it. and you find that good spot. Make sure that there's not a ton of bone right around that area. That's why I like to use these membranes that have the wings on the facial aspect, so you can go laterally a little bit, and don't overstuff those areas with bone graft, and then you can have really good adaptation of the membrane with the screw to the ridge.
And while I love, using the resorbable membranes with the tacks and the screws, if you look at a lot of our cases, you'll notice, we're overbuilding it. And a lot of the time the bone ends up, more apical. And it's great that we've, built that anatomy nicely in that apical area, but it does not recreate that buccal-occlusal line angle like you can do with these tie reinforced membranes.
So this is a good guy, a good patient of mine who Tom was unfortunately going to lose one tooth, and I'll give 10 cents to anybody who can guess which tooth that's going to be. Sorry, I didn't hear anything, so nobody gets the 10 cents. It's going to be number 8, the right upper central. And you can see how much bone loss there was, even on the adjacent teeth, especially on the lateral incisor. Really a large amount of bone. So what do? I know in this case, I could use a tenting screw. I could use titanium reinforced Cytoplast. But again, it's going to be at the time of extraction. So therefore, I'm not going to use titanium reinforced Cytoplast, except if I really want to use it, then I could do what I did, which is take out the tooth and just let it heal. And once it heals, that's all I did. Just take out the tooth. I didn't do any bone grafting, anything like that. Just take out the tooth, let it heal. And you could see how the soft tissue really ends up in a nice position over here. And now I can really have freedom to use whatever membrane I want. Doing some fancy imagery over here, just literally replicating in mirror image of the central. You can see already, predict beforehand, hey, Tom, we're going to end up with some interproximal deficiencies over here just because of the natural anatomy, the triangular shape of your teeth, the vertical loss of papillae. Know this ahead of time, and I hope that's okay with you, because recreating papilla is the toughest thing that we have in dentistry and is not going to happen, especially after performing some large augmentation. Communication expectations is key. So raise the flap, and you can see we're looking at somewhere about a 7-8 millimeter vertical deficiency, definitely towards the mesial aspect, 8 millimeters. And so in this case, I could have used a Profix kit with a tenting screw and a resorbable membrane. In this case, I decided to use a titanium reinforced Cytoplast. And this is looking at the facial aspect. You can see the defect goes all the way down towards the apex. And obviously mix my autogenous bone with allograft. I do sometimes mix in some xenograft, and there may be some xenograft in here. But you really want to make sure that the bone graft that you're placing is nice and red and bloody when you place it. Don't place it dry. So again, like we keep reinforcing, the most challenging screws put first, and those tend to be on the palate or lingual aspect. So place those screws on the palatal aspect over here, and then place my bone graft and place the screws. And you can see you can place multiple screws, however many you need in order to get some good adaptation. And in this case, 2 on the distal, 1 on the mesial. And I may have placed 1 on midfacial, but at least not in this picture over here.
So these are the hardest for me, these single tooth areas. And so did you have to go back and adjust over the occlusal to make sure it wasn't hitting? Did you go back with a scissor? Exactly. It was already fixated on the palate, and now you're using a surgical scissor to make sure that it's not in contact with the roots.
Either scissor or 15 blade, but you got to go back, and like we talked about with resorbable membrane, you have to, with non-resorbable membrane, you have to make sure that they're 2-3 millimeters away from the adjacent tooth, so that you can have soft tissue attachment here. Now, what happens in this case if on close to the distal aspect of the lateral incisor, you're into one of those titanium struts? That becomes a whole lot harder to adapt after the fact. So those are the types of things you've got to recognize before you screw the membrane in place, to know, hey, is one of my titanium struts going to be too close? Because you're not going to want to be able to adapt that afterwards. You're not going to want to, and you're not going to be able to. So this is what it looks like 3-dimensionally. You want to make sure, oh, this is my case. That was a picture.
Picture.
So you want to make sure that you get really good primary closure by by making sure that you stretch that tissue over the occlusal and incisal edges. Do my my Cytoplast horizontal mattress. I'm like Matt. I sometimes don't use a Cytoplast for that. I sometimes use Glycolon, but it's kind of touch and go, whichever I'm feeling at the moment. Place my Glycolon sutures everywhere else. Get really good closure, and then you let things heal up. And this being vertical, how long am I waiting? 9 months. It's a baby. And then you come back, and this is the moment that every surgeon loves, when you open up one of these membranes and it's kind of like peeling back a little gift, and you want to see what's underneath over here. So it looks like in this case, I did not place a screw mid-facial. I just placed the 1 mesial and 2 distal, and you slowly peel it back and remove your membranes. Here you can see the 3-dimensional augmentation that you get out of this. And again, that bone is rock hard. And you can see how it's augmented on the palatal aspect too. So you get all 8 millimeters of vertical augmentation. In fact, it's probably a little bit more coronal than the other central incisor. So probably grew a little bit too much bone, which is never a complaint of mine. I think Matt complains about that a lot, and that's why he uses a back action chisel and everything. And I asked for back action chisel today from my assistant, and she had no idea what that was. And I thought, oh boy, if she practiced with Matt, if she worked with Matt. So place my implant in a good 3-dimensional position with a really good buccal plate. You want to make sure you have at least 2 to 3 millimeters of buccal bone to that implant.
And you really grew, if you remember back in the beginning of the case, your bone peak was right here.
Yeah.
And so a lot of people will ask, well, could you have grown bone this way? That's not happening. The only way you can grow bone, you need a bone peak. So you got 100% defect fill from bone peak to bone peak, I would say.
Yeah. Yeah, and one thing you might notice over there is that I place my implants slightly subcrustal, because you kind of anticipate a little bit of vertical loss over time. So I placed this probably about 1.5 millimeters subcrustal. And just because I wanted to further augment any chance you could get to augment soft tissue, I wanted to do. In this case, I didn't use a custom healing abutment like I sometimes do. I just use a standard healing abutment, but I made a low poncho instead of using anything else, PRF or something. I actually used a connective tissue graft as a poncho to bulk up that facial tissue. That's a nice picture. And get closure. Yes, closure over the healing abutment, just because I don't care about anything. All I want is vertical height. I will go back afterwards if that healing abutment is completely closed, and I'll do a tissue punch. There's no issue with that. This is the final restoration by a great friend and great dentist, Paul Craneson. I can understand his challenge with trying to limit the amount of interproximal tissue loss, interproximal papilla loss, by making the tooth a little bit wider. It's a tough position to be in as a restorative doctor. This patient did not want to have adjacent teeth restored. If he did, then that would be a whole different ball game. But this is a tough restoration, a tough single tooth restoration for him to do. And from my perspective, I really like, obviously, that the facial tissue is even a little more coronal than the adjacent central.
Yeah, and the solution here, of course, is less triangular teeth.
Yeah,
of course, can't always get patients to go along with it. They don't care. They're not looking at the papilla. We're looking at it. Yeah, and so these are my favorite patients, probably.
Yeah, exactly. He was a great guy. He doesn't care. So this is another patient of mine. This is Rebecca. It was a similar case, but just a little bit bigger. So in this case, unfortunately, going to lose the 4 maxillary incisors, and there's a really big vertical deficiency. So when we take out the teeth, we did do some bone grafting, obviously not trying to really augment a ton, but just trying to gain something, and really did not gain much, but you could see the residual bone graft material in there. So again, secure the palatal first with the mini screws, and have my titanium reinforced membrane that again, placed after taking out the tissue, after taking out the teeth. Let the soft tissue heal before using these membranes. Don't get a lot of exposures. Don't do that. In this case, here I am making my sticky bone, mixing some autogenous bone in with it. And you could see the safe scraper, you could see the PRF, making the whole cocktail. At that time, you could see I was even cutting up some PRF membrane and putting it into the bone graft, but frankly, I didn't notice any difference and stopped doing that. Matt, do you do that or no?
No, I don't bother.
Yeah, just use it for sticky bone. So here, after I place the bone, secure the titanium reinforced membrane on the facial aspect. This case, I made a little wings, 2 wings around the anterior nasal spine to get good adaptation. You have to adapt these because you don't want to get exposures later on. In this case, I was like Matt and used the Glycolon for the horizontal mattress instead of the Cytoplast. And you could see that excellent soft tissue healing. You could even see that I did something on the upper right there. I can't remember what I did, but some type of surgery. Healed up well.
I think it was an implant. I think I saw it.
Yeah. And so look at the soft tissue healing once this is done. And that soft tissue is just, it's nice. It's pink. It's healthy. It's uninflamed. Nothing, no barrier coming through that. And you expose the membrane. And then again, that moment of truth when you start to remove the mini screws in reverse using your handpiece, and you take off your membrane. And this is the type of bone that you get. Again, this is rock hard. Did I wait 9 months on this one? I'm not quite sure, but in general, if I'm using vertical, I wait 9 months, and then the bigger the horizontal, the longer you have to wait. Smaller ones, you can wait 4 to 6 months. Larger ones, you want to wait longer. In this case, place 2 implants for lateral positions to support a fixed bridge. And again, place a soft tissue graft on the facial. Really just place like a sling suture around these healing abutments to be able to secure the connective tissue graft before suturing the flap back into place. Again, I don't care if I have coverage of the healing abutments and augmentation materials. That's allograft mixed with PRF and probably a little bit of xenograft in there too.
Now, I think I know the answer to this, but someone just asked, and it's a great question. If you're going back and doing soft tissue augmentation at the time of implant placement, which we're doing quite a bit for these larger augmentations, in general, you're not necessarily going back and having to release the flap and do this large periosteal release. Typically now we have enough release of tension just by raising a full thickness flap that you can put that soft tissue graft in there and still get really good closure. Am I wrong here? You're not doing an additional periosteal release at this time, are you?
I'm not. No, I'm leaving it exactly like that. Yeah. If Dean's cortical bone pin picnic table technique turns out well, if that turns out well, then I will jump for joy. I'm not sure if I'm going to jump right on the train, but I'll jump for joy. But you can look over here. It's incredible, incredibly impressive, at least the surgical pics. But knowing Dean, it'll turn out well anyways. So here you can see the soft tissue, the marginal facial tissue of where it looks like adjacent, according to the adjacent teeth. And you can see it's very, very favorable coronal incisal position or coronal apical position. And you can see the healing, the thickness of the soft tissue, the thickness of the bone, everything's lined up in place to be able to support a nice long-term fixed restoration here.
Here it is.
So this was an interesting one. This is the case that I posted about over the last week or so, where I did a vertical, a 3-dimensional augmentation on a very thin posterior ridge. And this patient needed 2 implants. And then it turned out that single tooth that was there but broken in this video, in this picture right there, it ended up needing to come out. but we were trying to keep it in the first place. So it was there, and then you'll see it gone later on. But needed 3-dimensional augmentation, and I'm going to be using a titanium reinforced Cytoplast membrane. And after making my perforations, so the reason why this case was so interesting is because this patient was gone partially because of COVID, partially because of finances, and partially because of I don't know what. She was gone for 20 months. I have never left something heal for 20 months. Have you?
Not on purpose.
Yeah, right. Never on purpose. So again, I use my autogenous scrapings and titanium reinforced cytoplasm to be able to get a 3-dimensional augmentation of this area. And so this picture, I want you to cement this picture in your heads over here. I took this picture at the time of the graft just to be able to show how close you can get with the screw to the mental foramen. That's the mental foramen right under it. I know there are a couple of bone particles. I wish I'd suctioned them up before taking this picture, but that is the mental foramen right underneath, right inferior to that screw. Very cool. Okay, the entire membrane is nice and exposed. Cement that picture in your brain. Get my primary closure. Everything looks great using the techniques that we talked about beforehand. Everything's healing nicely. After, I don't know, roughly 16, 17 months, she shows back up. We take a CT scan and I say, hey, this looks really nice. I'm pretty happy with this. Look at the cross-section views. Great. Again, very, very nice. Plan the case. You can see 3 implants over here because I mentioned that that distal abutment tooth is now going to be gone. So we're planning 3 implants using a surgical guide to be able to place those 2 distal implants. And unfortunately, the other one could not be an immediate, so it would just be extraction graft of that with placement of the 2 distal. Open up the site and everything looks mighty, mighty pretty. And then, hey, do you remember that picture before? So frankly, it didn't even occur to me what I was looking at over here. I didn't even think that was the screw. I was thinking that maybe I didn't put a screw there and that I didn't know what that was. And I wasn't quite paying such close attention to it. And then as I kept lifting the membrane, I'm like, oh my God, that's a fixation screw. So the bone, and there's a mental foramen right underneath it, just like in the last picture, the bone grew very nicely over the membrane. Now, is that a good thing? I guess that's a good thing, except if you want to remove the membrane, and it's not such a good thing. So, you know, how would you even remove that membrane right above the foramen? I was using a 15 blade to try to flake it off. And yeah, you're pushing on that bone right up against the mental foramen to try to flake off the membrane. Does it slip a few times? Sure. Does it slip into that mental nerve? Hopefully not. But let me tell you how long, or let me just tell you, do I wish that this was the only spot on this membrane that it happened? Yes, I wish it was. This happened all around the membrane.
That's crazy.
It was crazy. So that day, obviously, I was in deep doo-doo in the office because the surgery went way longer than I anticipated. And just to remove the membrane took 1 hour and 15 minutes. It was crazy. It also had this odd type of bone formation. But if you look back, way back at the initial picture, there was that little divot inside the membrane towards the mesial aspect. So all it does is just form exactly to the shape of the membrane. And, you know, when you remove these membranes at 6 to 9 months, that typically just blends in. When you remove it at 20 months, it's solidified. That was hard as a rock. I actually kept it in place because I'm going to do an uncovery and go back in, and then I'll blend it out. I'll smooth out the bone, but I wanted to keep it in place for now. I didn't want to do too much osteoplasty. Place my implants using a surgical guide and suture it up again. You can see I extracted the anterior tooth, did a ridge preservation graft, sutured up, and I'm going to come back and do a free gingival graft when I go in to place the healing abutments. And I'll do a little bit of osteoplasty if that bone is not turned over around those implants. Take a CT scan to be able to just make sure that the implants are in good position. And yeah, both implants look great.
Beautiful case.
Crazy case.
Okay, so I think, this is a really good point to sort of start our conclusion here, and that, there's so many different techniques that we use to regenerate lost ridge contours. And of course, these larger cases, you need to be very particular about the protocol that you're using and really master each of those steps, because of course, using these non-resorbables is a lot less forgiving. Someone asked for us to comment on titanium mesh. And, for me, the reason why I got away from titanium mesh was the difficulty in removing the titanium mesh, because you could have a really, really great result. And it really is because it's titanium and the body can kind of grow bone over those areas. While it's great for regeneration, I've actually had cases where I ended up having to remove a lot of that regenerated bone just to free up that titanium mesh. Not to say that, the materials aren't going to continue to get better. And now we have some thinner meshes out there. I saw, these preformed cages that they're making based on the CT scan. So these are all options available to you. In those cases, the critical thing is the periosteal release, right? Not so much the adaptation of those preformed meshes. But keep in mind, when you do these ridge augmentation cases, you go back, now you have all this bone. And a lot of the time we're doing that in a first stage, and now we're going back to place our implants. This is a lot of the time the scenario we're in, where we have very little bone below the sinus. Am I going to go do a lateral wall here and have to just basically, eviscerate all of that bone that I've just worked so hard to grow to get to my lateral window? And of course, we couldn't do another webinar without mentioning this internal sinus lift with NovaBone, because this is really a game changer. Israel is at the forefront because he's turned so many people, probably hundreds of people, he's taught how to do this technique. And so we can't end this webinar without at least touching on this. It's a very, very simple technique. Of course, we're using the Versa drills. We're using this NovaBone dental putty, mostly because of the fact of this application process. It comes in like a composite syringe. We use the 0.5 cc containers of the NovaBone, and we follow what I call a strict protocol. It's the Israel Puterman protocol here. And without going into too many specifics, what we're doing is we're infracturing the floor of the sinus without tearing the membrane. And those drills help you do that. And Israel's given me a lot of advice on doing this, because a lot of the time I was not getting the lift that I wanted. And it wasn't until I really started watching Israel's videos on this internal lift that I really started to understand and get a feel for what was happening.
Yeah, and it really is. It's a feel. Like Matt says, the first few that I did, they didn't work out too well either. And then I started to do more and more, learn the little quirks associated with it, make a couple of changes to some protocols that I knew. And lo and behold, you have something new, and that works very, very predictably. Went up to our buddy, our other colleague, Phil Walton, up in Toronto, went to his office to be able to watch him do some cases too. And I'm sure every one of you follows him as well. And he had a lot of trouble at first. And then all of a sudden it just came one click in his hands, in his head, about exactly how to do it. And now his cases are surpassing mine. There's no question about it. So it's sometimes it really just takes a one little click to be able to see what exactly happens. You can see over here that I'm using my 3D scope to be able to get a really good view of it. Visibility is everything. Like in anything in dentistry, you need visibility. And I've been using my scope and loving it, but you don't need to, obviously, as long as you have good visibility. You can see on the right-hand side, my assistant is ready with the handpiece, and she's ready. And then I pass her the bone syringe, and I'm not even looking down at that. We're just passing back and forth over the patient, not even looking down. We're both expecting exactly what to do. You get so used to these things. An implant with a sinus lift like this right now takes me about 22 minutes. And we're using a lateral window. It would have taken, an hour, 45 minutes to an hour.
And a lot more bone and a lot more risk, of course. Once you open things, that's certainly opening up to more risk. So this is a great technique. The keys to remember are to, start with the smallest size VersaDrill. We have some specific tricks that we're really, working out, the kinks to try to be able to use this technique for a wide array of cases. And I think if you guys are on Instagram, which most of you probably are, you're seeing that, people are loving it because of how simple it is. And for me, one of the things that I do in the middle of the procedure is after I know that I've infractured that floor of the sinus and I know that it's not perforated, again, I don't use the scope, but I use a mirror and get good visualization and see that it's intact. And I'll start adding my Nova bone. As you can see on this lower left picture, I'll take an x-ray, because at this point, once I know that this Nova bone is protecting my membrane, now on successive insertions of the Nova bone, I can actually have my final drill go into the sinus about 1 millimeter or 2 and really now elevate that membrane. And so I think seeing that video that I just played with Israel, inserting that bone probably 7-8 times before he even takes that x-ray or confirms, is really what you need to do. There's such a small volume of Nova bone that you're applying with each insertion. So I think that's important, is to not be, overly conservative with the amount of bone graft material.
We get a lot of questions about whether it is a 0.25 or 0.5. Frankly, I don't even buy the 0.25s. I just use the 0.5s.
And I'm finding I'm usually using at least 0.5 and then an extra half,
Exactly. Yeah. And when you're using small volumes of things, you tend not to want to open up a second one. And it's more cost effective to just buy in larger amounts. And you never have that thought of, should I open a second one? Should I not? Use the 0.5s, and oftentimes I'm opening up a second 0.5. Cost should not be an issue here. It's not expensive material.
And if you excuse me, if you are interested in learning more about the specific technique, here's another QR code. The webinar is available on demand on our website, surgicalinfluence.com. And please send us your cases, tag us in your cases, your Nova bone cases online. It's kind of been an amazing journey working with Osteogenics and Israel and Phil on the Nova bone, because it's something that really fits into so many of our practices. And we were both trained on using osteotomes, and we were doing that for quite a while. So it's not as if we went from doing lateral walls to doing Nova bone lifts. We went from doing lateral walls to doing osteotomes to playing with lots of different toys out there on the market. But this is one that is really simple. And if you know the modified protocol, I think you'll have a very easy time with it. I can't believe we made it. We did pretty good. Only 6 minutes.
6 minutes. Wow.
So that's pretty good. So we'll have a chance to go through some of these questions for all of you that stayed on. We really appreciate it. We hope this was very useful, and we'll of course go back and answer some questions now. But before I forget, the CE code is this FPW lowercase EB 321. All right, Israel. So I'll be the little doer here, and I'll go back and look at some questions here, because I think we did bring about some of them, but we didn't go through. There was a lot of good ones that I did miss.
There were a lot of good questions.
One of the questions that I had was, do you suture through the membrane if you're using stabilizing sutures? And the answer is I don't suture through the membrane. One of the reasons why is I don't use a membrane that really allows for you to suture through it. The membranes that I use a variety of different membranes, but none of them really do well being sutured through it. And because of that, I've kind of learned that we don't need to suture through the membrane. And so neither Israel or I, if we're doing the stabilizing sutures, we don't try to suture through that membrane.
Yeah. Jenna asked, and I didn't answer my part about the suturing technique with Glycolon. I do 3 forward, 1 reverse, 1 forward, 3-1-1. I don't use the 2 forward, 1 reverse like that study shows, but I don't have sutures come out, so I just never thought they need to change.
Israel, I just ordered one of these the other day. I'm going to let you tell everybody, what instrument do you use to tunnel?
I use a tunneling instrument. Every company makes tunneling instruments, and it's one that on one side is straight and one side has maybe a 70-degree bend to it. Mm-hmm. And mine happens to be blue, and we refer to it as blue. It's in every one of my surgical kits. I'm in love with it.
Well, one of my favorite doctors, he's actually my dentist, Dr. Hervas. He did a beautiful job. He's on here. He asked, why am I using a PTFE membrane for single sockets if I can just use exclude, which I think he means bio-exclude? That's a great question. Obviously, for small sockets, a lot of different things will work. Excuse me?
I think he said extend, or I read it before and I could be wrong.
I think it says use exclude. So I think he means bio-exclude.
Oh, exclude. You're right. Bio-exclude.
Basically, what I'm thinking is, for a case where I need to maintain that buccal-occlusal line angle, as much as I love bio-exclude, I'm using bio-exclude a lot more for sockets where I'm not even reflecting a flap. I'm using the bio-exclude over the top because of its, immunoprivileged properties and the fact that it's antibacterial and all these other things. But if I have to maintain a buccal-occlusal line angle, then I do want something that's a little bit stiffer. And there's a lot of different membranes that will do the trick here. But PTFE certainly gives you that predictable result. I love it, especially in the posterior for those sockets where I don't even have to trim the membrane, where it's just like the perfect fit.
Do you tuck the palatal aspect? I typically do tuck the palatal aspect. I've been avoiding tucking the lingual aspect on at least using resorbable membranes. I've been avoiding doing that, especially posterior mandible. Now and then you get into this rut of these lingual sequestrums, and it's just because you're exposing the bone, and it has a tough time adapting when there's a sharp edge to it. So try not to expose the lingual aspect too much.
Another great question is, do you really pack your bone grafts into the socket, or is it just loosely? We both have the same philosophy on this. I mean, we're compressing or we're compacting with a bone condenser. We're not packing it like amalgam. We do need, space for vasculature. And so it's really a feel thing. We obviously don't want any dead space. And so we start with a smaller sort of condenser to the bottom of the socket. And as we move more coronally, we can use a larger condenser, but it's not critical to overly compress. And I think that actually can only hurt you if you over compress.
Let me tell you why that's such a good question, because Babak Nui is one of the smartest guys around. He's a surgically trained prosthodontist.
So he probably knew the answer already, is what you're saying.
He probably knew the answer. He's a smart guy. Yeah, he's a good
someone else asked, is this known as Gore-Tex Sutures? Yeah, so PTFE, a lot of times we'll call it Gore-Tex or Teflon. And it's really incredible stuff. Obviously, we're using Teflon and PTFE in all aspects of modern life, and I always give in my bone grafting lecture, the opening discussion is, the gold standard membrane for guided bone regeneration is really Teflon. Something that's interesting to note, and maybe some of you caught this, is the first case that I showed, that was an older case. That was actually a DPTFE membrane. Right. And so the new membranes that are out are actually a lot more tissue friendly. They don't get exposed quite as much. And so that's something to think about.
And if they do get exposed, then they don't collect plaque. They're expanded polytetrafluoroethylene.
Exactly.
That's for fun.
Someone asked, do you leave the suture in for 4 weeks as well? Well, now I think 822. What were we talking about at 822? I think we're probably still talking about some of my socket cases, and the answer is yes. I'm leaving those sutures in until I'm ready to remove the membrane. That's why I like to use those sutures in those cases, because there's no reason to remove anything in separate visits. Contact Osteogenics for the recording.
Yeah, on Instagram, it's probably the easiest way, I would assume.
Absolutely. Let's see, any other good questions here? There's so many questions, guys. Thank you for participating. This makes it great for us when we see that there's good questions here. Someone asked if we could show an illustration of the stabilizing sutures. Where were you? You missed it. Wait for the recording.
Asked right before you showed it.
Yeah, that's possible too. So the question is, can you take a first bite of the periosteum? We tell people to do that a lot. If you're having a hard time, if you're putting your bone grafts in and then you're putting your membranes over the top and then you're trying to throw a stabilizing suture and you have a tendency of pulling that membrane out, one little trick that you can do is before you even adapt your membrane or your bone graft, you can throw that first suture that bites the periosteum, and then you can actually hold that suture, almost can reflect the flap with it while you add your bone graft and your membrane, because then all you have to do is bite the palatal flap. Now, when you bite the palatal, you have to go back through the palatal. Remember that. Otherwise, your incision, your suture is going to go through your incision, and you're not going to be able to revert your flaps because that suture is going to be holding down the palatal flap. That's something that we see all the time.
Grafting time of implant placements, do you perforate the facial bone before laying down your graft? Yes.
Yes, you should always try to. That's always an issue because if you have such a thin buccal plate, and sometimes it's kind of hard to actually decorticate without maybe damaging your implant. So in a lot of those cases, sometimes what I'll do is I'll actually decorticate beforehand. Unless I have good blood supply in those cases, sometimes we'll be okay without it. But for the majority of cases, we're decorticating.
Relative cost of glycolon compared to PTFE, Matt, do you know? I have no idea.
What was the question?
Relative cost of glycolon compared to PTFE. Ask your
rep. I know that obviously these types of sutures maybe are a little bit more expensive than like the chromic gut that I used to use, but it saves you so much time and it makes your surgeries look good. So I don't really even think about it. Sure, you don't have to use it for every case, but I would definitely, try it for some of these larger sockets and for some of these ridge augmentation cases, and definitely the soft tissue cases because of the beautiful soft tissue healing. But I have to assume that they're probably pretty similar in price.
Yeah. Doron, it really, honestly, it matters not so much what works best in our hands. It works best what's best. It works in your hands. Why is that tough to say? But that's what matters most. Honestly, we all use different membranes. Matt and I both use different membranes, and we use different membranes for different indications. Neither one of us use one membrane alone. We look at a site and we try to use the best membrane for that site.
Yeah, and we've been, the two of us have sort of been on a mission over the last 3 years to kind of figure out, what are the requirements of the case and what are the features of each membrane that lend itself to using it for that case. And so, sure, for some of those anterior cases where I showed you where I was using tacks, could I have used stabilizing sutures? Sure. But I had the anterior nasal spine in the way. I have a lot of lip pressure. And while I've done well in those cases, I've also been, underwhelmed when I go back to uncover. So I would rather be able to overbuild that, and you can overbuild more by using one of those membranes that you can stretch. And that was another question a lot of people asked. That stretchy membrane was BioGuide. That's a native collagen membrane. Z Matrix is a peritoneum membrane that we talked about. That can also be tacked.
Obviously native as well. Yeah.
Yeah, and it doesn't stretch quite as much as the BioGuide, but I do think it lasts a little bit longer. So again, that's just, showing you the features of each membrane. There's no perfect material for every case. I don't think any of us want to go into our storage closet and have 10 different membranes. But I think having 3 or 4 different ones, and that's basically what we show in our course. We want to have something that's a little bit stiff if we want to tunnel in a socket, like I think Israel showed in one of those first cases where he showed how he was using the glycolon and he was tunneling in his stiffer membrane. And then for these larger cases, we want to have something that we can stabilize with sutures, and we want to have something that we can tack. And if you have those 3 categories covered, you can pretty much tackle any case.
You place your bone graft first and then adapt the membrane and suture, or place the membrane first and then pack bone. It really depends. Sometimes for sockets, I'll put the membrane first. Actually, that's what I did today on a case. When a socket that's missing a little bit of, has a little dehiscence, missing a little bit of bone towards the coronal aspect, I'll put the membrane first, and then you can push the bone graft into the socket and push it towards the facial aspect against the membrane. That's the big advantage to putting the membrane first under the flap before putting the bone graft. But
I'm also paying attention in those cases to like how comfortable the patient is, how comfortable I am, how much access I have. If my assistant has a Minnesota apical to the defect resting on bone, and I can really adapt my bone graft and really form it the way I want, then I'll do that first. If I'm worried that things are moving around, then I'd rather get the membrane in there just to keep all those loose particles from kind of getting into the soft tissue and then having to worry about them wanting to get exposed later on. I did use 2 membranes in a bunch of those cases. A lot of the time, it's because maybe I had a buccal and a palatal component to the defect. Although thinking back on the cases I showed you, I probably was doing it just because I used like a 25 by 30 or a 25 by 30 membrane. And for a socket, that's too much membrane. You don't need that much, right? But I like it because I can place one laterally, pack my bone, and then I can put another one over that buccal-occlusal line angle. And we always talk about how, especially at our course, we talk about how I like those 2 layers because if one starts to move, the whole thing doesn't get displaced. And so I think there's a benefit to using that 2-layer technique. That's, I think, classic Daniel Boozer. I think that's where I picked that up from, is kind of using the 2 layers, not because I need double the membrane. It's just for handling purposes. It helps to confine the graft a little bit better. Israel, what do you do if you're doing treatment for an upper anterior and you run into the nasopalatine canal?
If you run into it, if it's in the way, you have options.
Okay.
You either work around it or you obliterate it and you sever the nerve. Typically, if that's going to happen, I've spoken to the patient beforehand because I know on the CBCT that there's a good chance that's going to happen. So I'll tell them about it beforehand, what to expect out of it, and to expect some temporary paresthesia towards the anterior palate, and that it generally does come back. But I really, honestly, I've been practicing for 12 years. I've probably done that 3 or 4 times. It's not something that I regularly have to do.
Same here. And then I think a great way to close is on some of these soft tissue questions. And we're looking forward to putting on a soft tissue course very soon. So keep an eye out for that. But the truth is, a lot of these cases where we're doing larger GBR, unfortunately, they do then require some sort of soft tissue augmentation procedure. Both of us, I've seen some of Israel's cases where he'll just do a free gingival graft later on. We'll stage the case. For me, a lot of the time, I'll try to move things back by doing some sort of a roll flap at the time of second stage surgery. But there's always this issue of you've healed the bone, you look at the CT scan, the bone looks great. You look in the patient's mouth and it almost looks like they had no surgery done. It looks like there's still a defect, and that's because the soft tissue is deficient. It's not always the bone. So if you don't have any keratinized tissue, you don't have as many options. You can do some sort of vestibuloplasty. I also like Urban's technique. The strip technique works really well, using just a very thin strip of a free gingival graft, because patients really don't get a lot of postoperative discomfort from that. And then using some sort of soft tissue scaffold just to not have an open wound. But those will fill in. The keratocytes will migrate to the site and really will create that thickened, keratinized appearance that we want around our implants. If we have enough keratinized tissue, that's when Israel and I are both starting to play with a lot of these scaffolds that are on the market. If we already have the mucogingival junction in the right place and it's just a quantity of soft tissue problem, both of us have played with FiberGuide, we've played with Volumax. We're still using soft tissue probably the majority of the time, just because that's, tried and true. And we've been doing that for the last 15, 20 years. But there are some really amazing new products that are out there that are showing some great results. Look for a case report we're doing together that should be in the IJPRD, hopefully within the next year.
There was a question about one of my cases. How did I retrieve the distal tenting screw? I didn't. I left it in place. I only retrieved the mesial one. How often is there recession from vertical incisions? Yeah, a big part of our course that we teach on GBR is talk about complications, and we go through that a lot. Where you have to make your vertical incisions in very specific areas, and because that's to be expected. It is possible with thin biotype patients that you end up getting recession when you make vertical incisions. There are ways around it and things to do. But yes, you have to be able to recognize that. Look around 150 and 200, 250, which do we use and when for titanium reinforced? It tends to be 250 in the posterior. They're a little thicker, and the 150s in the anterior. Thick biotype 250, thinner biotype 150.
All right, somebody just asked me a great question. Do you ever use fixation screws with PTFE membranes? So actually, one of our colleagues, one of my best friends, he's an amazing oral surgeon, Dr. Kozlowski, who just did our PRF training at our course last week, just sent me a beautiful case, and that's exactly what he did. He used fixation sutures with the PTFE membranes. It's not something I personally do, and I don't think I've seen Israel do that either, probably because the biggest fear that we have is just because of the memory in these membranes, because of the titanium. And once those sutures are gone, if it starts to lift up, well, then you're risking having a soft tissue dehiscence. Not to say that it can't work. And I'm like I said, one of my best friends and an incredible surgeon does do it, and he does well with it. I just think you have to make sure you're using something that's a little bit longer lasting than chromic gut, and you really have to have it adapted nicely, and have that fold, really, that memory in that titanium really be ideal. Because if it wants to pull back up, that's when you're going to get a late exposure of your PTFE membranes.
I like this question. Do you use implants as tenting screws in the aesthetic zone? The answer is a big fat no. I don't have the guts for that. And if it succeeds 70% of the time, I think that's awesome. But that would be a disaster in my practice if it succeeds 70% of the time. So you can have very nice results. There's no question about it, but you need something that works 95% of the time. And I don't have the guts to be able to say that works 95% of the time.
Yeah, I mean, that's a real practice management question, I think, because when we talk about this a lot, we like to take every opportunity we have to grow bone. And so if you do use your implant as a tenting screw and it doesn't work out perfectly, can you regraft it? Sure. But now we're regrafting an implant that's been sitting there and the bone didn't take the first time. It's very difficult to decontaminate it. So I would rather, spend that extra couple bucks on a tenting screw and then go on later and place that implant and know that I can always regraft it, or graft additionally if it failed around the tenting screw. But if it failed around my implant, now I'm really, 2 steps forward, 3 steps back, whatever that expression is, right?
How do you handle exposure of titanium reinforced membranes? Well, we could go on for 45 minutes on that. Early, bad, obviously. Late, okay. How do you handle them? Try not to get them. Get good release of your tissue beforehand. Make sure you have good release of your tissue. Make sure you have good, healthy, thick tissue. And if it happens, it'll be very small and most likely late. Manage your membrane. Don't have any sharp edges. It's all about preventing, much more important than how do you manage, to be honest.
Pre-op antibiotics is something that we both try to do in most cases. Obviously, that's typically a question we get asked is what type of antibiotics. Obviously, amoxicillin and that class of drugs is our first line. Patients that are allergic to penicillin, we obviously have a lot more issues because we don't really have a great antibiotic to go with. Typically, I was giving clindamycin, hated it. Israel turned me on to using Keflex, and that's been doing really, really good.
Ceftonir.
Fancy.
Yeah. Obliteration of the vestibule after GBR in the anterior maxilla. I think you answered that question. Another great question by Babak, but you answered that, I think, with either a free gingival graft or a palatal rotated graft to be able to gain some soft tissue on the facial aspect.
Here's a good question. I know Israel's answer. I'll give you mine. When it comes to immediate anterior implant placement, what is your protocol for bone grafting around the implant? So for me, I don't like too many choices in my particulate bone grafts. They say the cheesy statement, I'm not particular about my particulate. I like to have a good 70-30 mix or a 50-50 mix available. I'll use that for all of my ridge augmentation cases. I'm using the same bone graft for my sockets just to keep it simple. The difference is I'm mixing autogenous with my larger ridge augs or even my larger sockets. Israel mentioned to you that he does use some xenograft for his larger GBRs because he likes to maybe almost make like a what do they call it, like a sandwich technique?
No, actually, I mix it up with the allograft and just really mix it all up together, just to be able to give some bulk to it. It's much longer lasting and just provide some extra bulk. It might be more mental, psychological in my head.
And tell them what you're using around your immediate implants.
Around my immediate implants, I'm using xenograft, xenograft to collagen.
Awesome.
Comment on tie mesh. Oh, that's a good question. What's a comment? Challenging? Hard?
Yeah, I mean, I think the interesting thing for me when I first learned about tie mesh, as periodontists, we're told you need a membrane, you need a membrane, you need a membrane. Well, then you can see these beautiful titanium mesh cases and they're not using a membrane and it's still working. Why? Because you just have this superior amount of stabilization. The blood clot is all confined to that. Everything is confined to that defect so nicely, and you can do really, really well. There's so many different titanium meshes out on the market now. We used to do this cage technique, and I always show these cases in my presentation of cases that look amazing, and then other ones that just completely fall apart. And I'm not being critical of any company or anybody, other than to say that it just is not really for me, because I don't like to babysit cases when they open. And with titanium mesh, I find that that's what you're doing. And a lot of the time, even if it opens, you'll still work out okay. Just like Israel mentioned with the titanium Ptfe cases, if they open late, you'll baby them a little bit, but you'll still usually regenerate enough bone so that you can continue along the path and get to the end of the case. But with titanium mesh, once it opens, you're just babying it quite a bit. And for me, I just don't have the patience for that. So if I'm going to do a large case, I will go with titanium Ptfe. And I just don't know that there's really that much of a need for it. Now, what I'm very interested in, like I mentioned, was these preformed, titanium meshes, because to me, that's doing all the work prior to surgery and all the planning. And that just makes the actual surgery a lot easier. And that's something I think we'll both probably be doing more of as we'll all be doing more of as the technology just continues to improve.
My biggest issue with the titanium mesh that I always found is on removal of the mesh. It could take you half an hour to remove the mesh, and you're doing everything you can not to remove a lot of bone graft with it, a lot of regenerated bone with it. So honestly, I haven't used a tie mesh in half a dozen years or so. It's completely switched over.
All right, I think we'll close with just a couple practice management questions here that were good. Do your fees differ based on the size of the GBR? And the answer is yes, of course they do, because you're using lots more material. You can also think about in terms of the amount of time that you have to take, right? And so you have to be comfortable with your fees. One of the best lessons I learned was, advice from one of my mentors was charge enough that if it fails, you can do it again for free. And so that's one way to think about it. But don't sell yourself short. I mean, there is risk in these cases, and you're using a lot of material. You start adding up the cost of the scrapers and the membrane and the tacks and the screws and the appointments and all that. So I think depending on where you practice, the fees are going to be vastly different. But we definitely do charge more for the larger ones, for sure. Do you ever leave a membrane open for lateral augmentation? I think that you can do okay, but I think it's a big risk, especially in this case, like if you're using titanium reinforced. We know that these new membranes, they don't pick up as much bacteria and as much plaque. But for us, to have a patient walking around or ending up in their general dentist's office after one of our surgeries and just to have them stare at this titanium reinforced Ptfe that's not covered, to me is just way more risk than I want to take. The disadvantage of leaving things exposed is twofold: increased risk of infection, and then increased chance that you're going to lose your volume that you put in there. And so I don't recommend it. For ridge augmentation cases, when you're using collagen, I think there are those cases where you can get away with leaving it a little bit exposed. And actually, sometimes when you're trying to close it, but maybe there's tension and things open, you do really well because soft tissue will still grow over the collagen. Whereas with the titanium reinforced, you have to baby it until it closes. And in those cases, I don't think it will close. I think you're babying it until that point where you say to yourself, well, if I don't take it out, it's going to separate, or it's already separating. So the anonymous person that asked that, I'm sure you can do well with it, but it's not something that we recommend as part of a protocol to do ridge augmentation and leave things exposed. I think getting primary closure is a lot safer.
These are all great questions. We have to answer Jess's question. He's a good buddy of ours. So 2 layers of resorbable membranes for GBR. Is it for extra membrane thickness, stability, or dimensional limitations for coverage? My perspective, dimensional limitations for coverage.
Absolutely. And stability a little bit, because if we always over trim, and if you need to keep your graft confined to the defect. especially if you're not dealing with a real concavity, so you have nothing to pack into. Having that membrane extend laterally is going to make the ability to stabilize with sutures a lot easier. And of course, with tack, same thing. If your membrane's not lateral past the defect, you're not going to be able to keep your bone graft where you want it to be.
So many good questions here.
Well, we'll save the ones that we didn't answer for next time, I guess.
There you go. Only 87 left.
Amazing that so many people stayed on this whole time. We really appreciate it. We, again, follow us for updates on more webinars, more cases. Send us DMs. Let us know what you want to learn about, because we're always, brainstorming and trying to think of ways to incorporate, what everybody wants to hear. So that's why I said, soft tissue should be coming up soon. So keep an eye out for that. Thank you guys for joining us. Everybody have a great end of the week. Israel, always a pleasure.
Always mine. And thank you so much to Osteogenics for hosting us and this webinar. They are a great company to work with, and you will enjoy them as well.
Thank you, everybody. Have a good night.
Thank you, guys.